Hi everybody, I'm Dr. Vizniak with the amazing
Carolyn Yukai
and the amazing
Chelsea Leander.
And today we're going to take you through an example of a OSCE style exam, oral practical or clinic exit of the basic process you want to follow. If you're looking at this process, it is the hip nurse process all the way through. As long as you do that, you won't get lost. So without further ado, I'll go ahead and start. I will be the proctor. Here we'll have our fantastic examiner, and here we'll have our fantastic patient, and we will proceed as though the rest of this is the fun exam, a celebration of learning, if you will. So let's go ahead and get started. So today, Chelsea, your patient has come in, and she would like nothing more than to know a list of, sorry, pardon me, wrong exam, okay?
It's confusing from the get-go.
Come in, we suspect that she might have a L4 lumbar disc herniation. Please go through and give us the definition of the condition, history, signs and symptoms, differential diagnosis, and then proceed as though the rest of the exam is this is patient in your office.
Okay. So an L4 disc herniation is when a disc bulges in the lumbar area. So normally your patient will present with a history of like picking up and turning type of emotion, and they'll say that immediately there's a numbness, weakness, or tingling down their leg. Other symptoms may include while a patient is sitting, if their leg is straightened, they'll get the repercussion of those symptoms, and any bending is going to exacerbate those symptoms as well. So for this pathology specifically, I want to DDX anything else in the lumbar that can be impinging on the nerve. So that may be a tumor, it could just be trauma to the area, so like hypertrophy of the muscles, and it also DDXing a Facet syndrome.
Okay. All right. Could it also be potentially osteoarthritis or anything else?
Absolutely, yeah. Okay. And osteoarthritis can technically lead to a disc herniation down the road.
Okay. Let's go ahead and continue with the rest of the exam as though this patient is attended into your office.
Okay, so the first thing I'm going to do after getting history is I'm going to inspect. So I'll have Carolyn lie on your stomach first.
So one of the key things to get at the very start is make sure you know how the equipment works. So there's a little switch right here, and she's going to go ahead and lay face down to start with, and away we go.
Okay, so because this patient is likely presenting with lower back pain, as well as lower extremity, is it okay if I do a hands-on assessment?
Yep.
Okay, and let me know if there's anything that's painful or uncomfortable. Don't do anything that you think will cause you any further injury. So first I'm going to inspect the area, so inspecting from L2 all the way down to the sacrum, and I'm not expecting to see any bruising, erythema, or inflammation in the area, because this was a twisting type of emotion and not really a trauma type of a accident. And so that's my inspection, and then I'll go into palpation. So palpation, we know we want to start distal from the area, so we'll start up towards the back. And again, Carolyn, just let me know if there's any pain as we palpate down. And then I would also start more from the sacrum up, making sure that my grip is nice and wide. And when we come closer to the area of L4, she may present with pain guarding. I'll likely see and feel a hypertonicity along the rectus spinae of L4. But she's not going to get that numbness and tingling down her legs until we put pressure on the disc. So now we're going to go into range of motion. So Carolyn, I'll get you to sit up again for me. Now I like to do range of motion for the lumbar sitting down because you isolate the lower back. So I'll just have you repeat my motions. First we're going to lean forwards, and this will likely exacerbate her numbness, tingling, weakness down the leg. Okay, and then coming back up, you can extend your back. Good, and then we're going to come to the side.
All right, so your patient leans to the side like that, experiences a little bit of pain and discomfort, shooting pain down the leg. What tissues are being compressed?
So here you have the left facet is being compressed, some of the erector spinae are being compressed, a little bit of the quadratus lumborum would be compressed.
Okay. All right, go ahead and continue with the rest of your examination.
Okay, and then we'll have a twist. So we'll have you twist to the right, and then a twist to the left. Those should all be minimal with pain. Do you want me to go through all of the ranges of motion?
No, you can just go ahead and pick one that you think is most indicated, and that's fine.
Okay.
So, all right, let's go ahead and continue on with the rest of the exam.
Okay, so for nerves, she is coming and complaining of numbness, tingling, and weakness, but I can go ahead and test to see how her nerves are doing. So we'll do a special, we'll use this. I would like for the table to be a little bit higher, but unfortunately it's not. But this would be testing for L4, and we know it's a L4 disc herniation, so likely this reflex would be not present. L5, and then S1 should be fine. And depending on which side the disc is bulging, we may get both L4s that are, so both of these reflexes would be minimal if it was on both sides that the disc is bulging, but we'll pretend it's to the right for the sake of the exam.
Okay, all right, can you go ahead and move on then?
Sure.
Thank you.
Okay, so next I would do special tests. Do you want me to do referrals?
Yeah.
So referrals, anything that would refer, so to the lower back, anything that could refer would be something from the upper back, so thoracic, mostly thoracic, or any kidney pathology or prostate pathology we want to rule out. Also anything below the lumbar, so SI instability or hip pathologies can refer up towards the lumbar.
Okay.
And then for special tests, my first go-to test would be a straight leg raise. So Carolyn, what I'm gonna do for you is I'm just gonna raise this leg out. And if it's a significant disc herniation, then you would get the sensation of tingling and numbness down your leg. We can exacerbate this by by flexing the toe a bit, and then I'll have you lean your head down. Good, and we can again add some overpressure to that. So that's like 3 or 4 tests in one because they're all pretty much the same.
Okay, excellent. Continuing on.
Do you want me to do another test?
Yes, please.
Okay, so the other test I want to do is a compression test. So I'm gonna start to load in. I'll have you take a breath in and out.
Okay, and what
Good.
findings do you expect to see here?
So again, I would get the exacerbation of the numbness, weakness, and tingling down her leg, and then if I do a decompression test, it should make that better. So I'll have you take a breath in and out, and that's because we're decompressing the spine here.
All right, we're going to pick another test just at random, just to make sure you've studied your full list of examination processes. Okay. Do a scour test of the hip for us.
Yes, so we'll get you on your back, Carolyn. So a scour test is mostly testing for osteoarthritis of the hip. And so it can also be positive for a labral tear as well. So first we're going to start with just the range of motion of the hip. And we want the full range of motion, so we're getting the entire hip socket. And then I'm going to put a little bit of overpressure. Good. And then we're going to go a little bit more, so basically all my body weight. And in this pathology specifically, this would be negative, but positive for osteoarthritis. So we're looking for a grinding, crepitus type of a feeling and sound.
Okay. All right, that concludes this portion of the exam. What are some treatment options you might offer this patient?
For L4 disc herniation, so obviously to avoid the bending, twisting action, I would like to do some distraction exercises. So if you have a table that you can flip upside down to just distract and allow that disc to come back in, I would opt for that. We can do some analgesics, so NSAIDs or ice packs, or if you want to go the herbal route, curcumin. Those would be, and acupuncture is always great along the erectors.
All right, so looking at this patient, what are 5 key factors that will allow her to heal faster?
So community, adequate sleep, that's 7 hours or more, drinking enough water, having a positive outlook on life and your healing process, and good nutrition.
All right, and next question, if you were to look at a postural assessment, what are some things the plumb line would fall through in an anterior to posterior view?
Anterior to posterior.
Yeah, so looking from the front.
Yep.
Yep.
So we're gonna look at you can stand up if you want. We're gonna look at the pubic bone and then the xiphoid, and I'm assuming the nasal bones.
Okay. All right. Thank you very much. That concludes this portion of the exam. Okay, so we'll stop right there and I'm going to give some feedback on it really quick. Typically we do both sections, but for right now, some quick feedback that we can look at. Number one, fantastic job. Let's go ahead and sit down. Okay. All right. Really good job here. If you look at the grading form, we looked through it. Excellent definition of the condition. You went through and described history, signs, and symptoms really well. One of the things I might have added as well, it's key for disc herniation. Symptoms are worse with coughing, sneezing, and straining. Always think about that Valsalva maneuver when you're looking at this, right? Coughing, sneezing, straining. All right, then what else did we have? Yep, good DDX list that you went through, which is fantastic. Intro statement for the palpation, a little bit late.
Oh,
Hands were on, but okay. Hands were on. All right. And what you did really well is you checked in a few times to say, is that okay? Can we go ahead and proceed? You absolutely, positively want to follow through with your patient on multiple visits too, or multiple check-ins to make sure they're doing okay. All right, so one thing that didn't happen though, the only place I could really take marks off on this basic exam right here was you didn't give an intro statement for the range of motion assessment, right? So when you're taking somebody through, you definitely want to say, please follow the actions that I do. If anything's painful or uncomfortable, let me know right away, and
don't let me do anything that will cause further harm or injury.
Or you don't do anything that will cause further injury. Like let the patient give them the power back and they can tell you when to stop. But otherwise, the rest of the exam is excellent. Good check of the dependent reflexes. So absolutely counting for you to see your knee for 1 second. Absolutely L4 patellar reflex, L5 medial hamstring reflex that most doctors don't check and therapists don't check, and S1 down here at the bottom. So really good job there. If you're also doing sensory checking, because this was an L4 disc herniation, notice some tingling potentially on the medial side of the leg as a branch of the, say it if you know it, say it if you know it.
Fibular nerve.
Good guess. Saphenous nerve. Okay, saphenous nerve. A branch off of the femoral nerve, as we all remember from our basic anatomy. All right, okay. And then the orthopedic tests you picked were great. And in fact, what you did that was fantastic is that straight leg raise in a seated position. Why not? Because she's already in this position. If it's not too bad, lifting the leg up like this, where she brings it all the way up, this angle at the hip is the same angle in a supine straight leg raise, except gravity is pushing down on this, right? Excellent variation. As an option, I might have added a little bit more to it and said this is going to be a Bragard's test here with a little bit of dorsiflexion, and then you went into full dural slump or maximal where you had her all the way down like this. So all of those are excellent actions that she did, and the fact that she combined them really shows that she has a good level of clinical understanding of what we are learning and trying to get across for our assessments for patients and her ability to help them in practice. So super good there. And then basic understanding, of course, key factors, prognostic indicators, and postural evaluation. It has been a while, but one of those key things we want to check. Typically, if you have a disc herniation, patients tend to lean away from the side of injury, although sometimes they can lean towards, but usually away from it. And yes, of course, treatment options should always include from least invasive to most invasive, ADLs, home care options available, and then any treatments that you might offer in office, which was really, really well done. So, do you have any questions?
I don't think so.
No?
Was the plumb line right?
Yeah, the plumb line's right.
Okay.
Yeah, okay. Pubic symphysis.
This is the sternal.
Suprasternal notch or xiphoid process, and then you would have went where you said nasion or nasal bone to the center like this. So that's kind of your basic lines to look at. And I know you probably haven't seen that in probably 2 years, I'm going to guess.
It's been a while, yeah.
Been a while. Yeah. Okay, so super good job right there. So that's the start of it. So hopefully this is helpful for you on your exam processes. And if you're looking to see these doctors out in practice and therapists out in practice, I will put links to their clinics down below when we're done here, and away we go. Thank you very much for your time.